Okay, these are the murmurs, and you've got over here the aortic, or the cold areas, the whale and the guy frozen in the ice block, so aortic. You got the mitral mountains over here, and the VSD and PDA down here. We're going to talk about aortic stenosis. This causes an increase in afterload. It leads to a left ventricular hypertrophy. There's a turbulence and flow going through the narrow orifice during ejection, leading to systolic murmur. Silly Arctic man rides up and down. So it's a crescendo decrescendo systolic murmur. It commonly radiates to the carotids. That's what this is, the carotid artery. So that's aortic stenosis. Pathology-wise, you get calcified deposits on aortic cusps, fibrosis of the cusps, and I can't even read my own writing. But anyway, clinically you get angina, syncope, CHF. Course is late peaking. You talk about crescendo, decrescendo, systolic ejection murmur, and you sometimes get an ejection click, which radiates to the apex into the neck. Pulsus parvis of tardus, which is a peripheral pulses, are weak and delayed compared to the heart sounds. Carotid bruit, S4 usually present, and you get left ventricular hypertrophy. Go down to diastolic murmur. You've got, or diastolic murmur, you go to aortic regurgitation. This allows blood to flow back into the left ventricle during diastole, causing an early diastolic murmur. Excess volume at the end of diastole can increase the pulse pressure, and seeing the differences between systolic and diastolic blood pressure. It's a high-pitched blowing sound. It's also got some interesting signs that can go with it. You've got Messet's sign. I'll even write this down. M-U-S-S-E-T. Messet's sign. Messet's sign is a bobbing of the head during systole. So the person will nod their head back and forth. You've got Corrigan's pulse, which is a water hammer or bounding pulse. You've got Quincke's pulse, which is a blushing of the nail bed when the nail is lifted upward. You get a pulsating uvula. You get Austin Flint murmur, and that's a regurgitation. This stream hits anterior leaflet of the mitral valve, and it causes a vibration. Now, treatment, you've got aortic valve replacement when injection fraction is less than 55%. You get digitalis, diuretics, ACE inhibitors, and not usually responsive to nitro. So keep those things in mind. Over here, the mitral mountains, they rumble. The mountains rumble. So that might be something that you'll see. Mitral stenosis. Often the left atrial pressure is greater than the left ventricle pressure, and this can cause that backflow, and respiratory distress can happen. And when this flows back in the heart, it is a mid-diastolic, an opening snap, and you've got the mountain is stiff, causing a rumble. So those things are all there. This often presents about 10 years after rheumatic fever. Got dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, low frequency rumbling in that mid-diastolic murmur, followed by high-pitched opening snap. Treatment, endocarditis prophylactics, valve replacement if it's really severe. The hallmarks enlarged left atrium and elevated left atrial pressure backing up into the lungs, causing damage. So you got the lungs here. Also an opening snap or mitral stenosis. Over here you've got mitral regurg. It's a holosystolic, which means it happens during the whole systole. It's a high-pitched blowing murmur. It's best heard at the apex, and it radiates to the axilla. S3 might be present. Acute cases may present with pulmonary edema, pulmonary right here in red. Chronic can present with failure and weakness on exertion. Systolic, holosystolic. Mitral prolapse is right between. In most cases it's asymptomatic, but you get palpitations, syncope, diffuse chest pain. It has a characteristic systolic murmur with a mid-systolic click, but it can lead to mitral regurgitation, so you know, you want to make sure you try to treat that. Down here at PDA, patent ductus arteriosus, you get this continuous machine-like murmur. Very loud, and you can't miss it. VSD is the ventricular septal defect. It's a holosystolic, systolic. The whole time you're going to hear that during the systole, and it'll be usually in a younger child that you just pick up. So those are the murmurs. If you know each one and their characteristics, you get a whole bunch right on the test.